All right, welcome back. Andrew Penn here with the penultimate part of this lecture. Before we return to Emperor Norton, let's talk about some special populations, particularly women, older people, young people, and the thorny topic of cannabis and psychotic disorders. Now, women who have schizophrenia, there are specific concerns that we want to think about, particularly around pregnancy and fertility. Uh, a lot of our antipsychotic medications, particularly the older ones, but a few of the newer ones, such as risperidone, can increase prolactin levels. And when prolactin levels are increased, fertility is impaired, in addition to causing breast tenderness, breast development in men, and lactation in all genders. It's also important to keep in mind that some of the medications that we use as adjunctive agents, some of the anticonvulsant medications that we might use as mood stabilizers in a patient with bipolar disorder or a patient with schizoaffective disorder, some of those are teratogenic and can impact the effectiveness of oral contraceptive medications. There are also significant challenges for patients with severe mental illness in parenting that we want to be mindful of, that successful parenting may require additional psychosocial support for a patient with severe mental illness. And then, of course, as our female patients get older, their antipsychotic effectiveness can decrease as their estrogen availability goes down. So there may need to be adjustments in a medication that has been stable for many years when a female patient gets to the age of menopause. The question of pregnancy and antipsychotics is a very tricky question, and this, with really all medication classes, requires a nuanced risk-benefit balance. Now, of course, a lot of pregnancies are unintentional, and that's a different question, but if a patient is intentionally wanting to get pregnant while on an antipsychotic, that requires a nuanced conversation. Uh, Antipsychotics are not uniformly contraindicated with pregnancy. Some have more problems than others. Some adjunctive medications can certainly be problematic, such as valproate. And so this is a conversation that you're going to want to have in conjunction with the person who's providing the obstetrical gynecological care, and also the patient, and if their family is involved, their family as well. But in general, moms with schizophrenia are going to need a lot of additional support. Now let's turn our attention to older adults. So with older adults, you have the combination of not only the diseases of aging, but also for some people, their psychotic illness can have a progressive course. So as they get older, they may be more prone to developing dementia at an earlier age, for example, and so they may need a lot more support than your average older person. And then, of course, because of the changes that happen in pharmacokinetics and pharmacodynamics, particularly pharmacokinetics, there may be decreased ability to absorb and to metabolize the medications that we're using to treat these conditions. And so adjustments may need to be made there. And then some of the side effects that go along with them, say the anticholinergic side effects of some of the antipsychotic medications, can become problematic as acetylcholine is increasingly needed for normal cognitive functioning. And then, of course, finally, we want to be thinking about maintaining social support for our elders with severe mental illness. There are some psychotic presentations which can present in older people, particularly people with Alzheimer's dementia, with Parkinson's disease. There's also psychotic-like symptoms, particularly visual hallucinations that show up with Lewy body dementia. And so people with psychosis of Alzheimer's disease often will have visual hallucinations, which are different than people with schizophrenia, who often have auditory hallucinations. And a lot of times their hallucinations, and this is also true with Lewy body disease, their delusions or their visual hallucinations are not particularly bizarre. It might be that they turned and they saw somebody they know sitting next to them, and then they turn back and that they're not there anymore. And usually people that have Alzheimer's disease don't typically have a history of schizophrenia, though of course they might. And managing Alzheimer's disease with antipsychotics is tricky. We'll talk about this more in the psychopharmacology lecture, but there are black box warnings to manage that make that particular population especially challenging to address with antipsychotic medications. Now we're doing this sort of in backwards order, but let's really pay some close attention to young people, because this is really where we can make the largest impact. Now, of course, as I mentioned before, schizophrenia often emerges in this sort of juncture between adolescence and young adulthood. And increasingly, it's become clear that if we can intervene as early as possible, even when somebody is in a prodromal state, we can make an impact. And often we can make that impact with a combination of preventing substance abuse, providing additional psychosocial support, and getting in with antipsychotic medications at the earliest signs of illness, and also providing additional support so that young people who are developing an emergent psychotic illness are getting support with their schooling, with disability accommodations, with socialization. And I'll talk more about cannabis in a moment. There are these early psychosis intervention programs, sometimes referred to as PrEP programs, where high-risk individuals, say somebody who has two parents with severe mental illness, can be identified because they probably have genetic loading, and then providing support not only for the patient, but for the family as well, and getting people into care if they need a higher level of care faster rather than waiting till things really fall apart, and getting that treatment at an earlier stage. So focusing now on substance abuse. So cannabis is a particularly challenging issue with young people and the development of psychosis. So we know, for example, with bipolar disorder, that people who are abusing substances tend to develop their bipolar symptoms at a earlier age than people who are not using, on average about 3 years earlier. And so that's concerning, because that means that's 3 years of additional disease. It also means it's 3 years of loss of role development. So to develop a bipolar disorder in your sophomore year is very different than developing it a year after you graduate. And we also know that cannabis-induced psychosis is more likely than other substance-induced psychoses, such as amphetamine-induced psychosis, to convert to bipolar disorder. And I know I focus mostly on schizophrenia in this talk, but bipolar disorder, while it is episodic and in that way different than schizophrenia, can also have significant psychosocial impact. And so that about half of people that presented with a cannabis-induced psychosis would convert to bipolar disorder and schizophrenia. So the take-home message for this, for me, is if I have a patient who is presenting to me after a freshman year of using a lot of cannabis and now is developing a paranoid presentation that's suggestive of schizophrenia, I'm sitting with that knowledge that there's about a 50-50 chance that that person is going to get better, about a 50% chance that they are going to proceed on to either bipolar disorder or schizophrenia. And if they're going to develop schizophrenia, they tend to do it a little earlier than those who developed bipolar disorder. But that's concerning to me. And the reasons for this are complex. They're beyond the scope of this lecture. But we definitely have seen through neuroimaging that THC disrupts certain networks of the brain, particularly in young people. And we see particularly this one area of the brain called the default mode network, another area called the salience network. And it's thought that disruption in these two areas of the brain is actually what causes the experience of cannabis intoxication, that feeling of being stoned. And that the salience network of the brain may be a very key network in switching between this key area of the default mode network, which is largely involved in introspective, inward-focused attention, and the executive network, which is involved in focusing on outside events, such as your going through your email or focusing on a paper, that we need to be able to switch between those two modes of the brain relatively easily. And the salience network may be part of that switching mechanism. And that part of what might be happening in schizophrenia is that there's disruptions in that ability to switch so that the person stays in this inward focused attention. They have difficulty focusing on things on the outside, or things that are not really salient take on more importance to somebody who's developing schizophrenia. Maybe this helps to explain things such as ideas of reference, where every yellow car has a significance to their paranoid delusions, whereas most people are looking at the yellow cars and saying, well, that's meaningless. So I'm not an absolutionist when it comes to cannabis, but I really do feel strongly that this is a drug that is best saved for adults. And the longer that we can forestall cannabis use with our young patients, every year we get closer to, I would say about 25 is ideal. Maybe wishful thinking, I realize, but the longer we can get to, the longer we can prolong cannabis use, really the better our patients' chances of developing a healthy brain will be. So this is really my harm reduction take-home message, is just if the longer you can wait, the better. So just in review, some key points about psychosis. Psychosis is, of course, not a diagnosis. I hope that's clear by now, but it's a symptom, and psychotic symptoms cluster together in syndromes, which we can then perhaps identify as a diagnosis. But psychotic symptoms by themselves, a psychotic symptom by itself, such as a delusion or hallucination, does not make a disorder or does not make a diagnosis of a disorder. And there are many other things such as substance use and medical conditions that can cause psychotic symptoms. And that psychosis is often a syndrome that changes over time and is often preceded, the emergence of psychosis is often preceded by these prodromal, more subtle signs of symptoms. And we should always be asking about the content of somebody's thoughts so we can understand if those thoughts and ideas put them at greater risk for harm. And then in schizophrenia, more specifically, this really is a condition which causes great neurodevelopmental and social disruption, particularly of the tasks of early adulthood. And it's not just, it's way more than just hallucinations or delusions, particularly these negative symptoms, such as the lack of energy and motivation, really cause significant disability. And just to be clear about that, many people can go to work hearing voices, for example, but if they have significant avolition, they're going to have a really hard time just leaving their house. And that we need to take care of the whole person who has schizophrenia, because the metabolic effects of medications, the use of tobacco, can significantly reduce not only quality but quantity of life. And that we need to extend our treatments beyond just medication and really treat not only the patient and their psychosocial goals, but also the whole family, because this really is a family disorder. So in our last section, we will return to Emperor Norton.